Redwood Mednet is a small rural health information exchange service, and we're located in Northern California. We started in 2004. We're an outgrowth of the Physicians Technology Steering Committee from the local medical society, and we serve primarily unaffiliated small practices or hospitals in the region. And it's important to understand that this isn't an entire community and every facility is participating. It's there are a lot of teams to a certain extent, and so we are the service provider for the small unaffiliated sites. We generally don't refer to ourselves as a health information exchange. Redwood Mednet is a health data delivery service. We enable the data to get delivered from point A to point B. We're really a network service in the middle. So we handle bidirectional test ordering and results delivery for laboratory and radiology. We have e-prescribing services going on and accumulate a community medication record. We are working with syndromic surveillance and disease reporting. And so these are the core types of services that our technical and policy approach is working with. In terms of meaningful use, that's right in our sweet spot. Meaningful use is actually really a tightly constrained set of options, and we can hit every meaningful use option that a provider may need to address if data is moving from their EMR to another EMR. We don't install EMRs, we don't operate EMRs, so that's site level detail. So the meaningful use measures that are engaged in tracking smoking status or individual data elements that we recorded locally, that's not our issue. Our issue is the transport between sites. There are two main points to sustainability. The first is keeping costs down and making them reasonable, keeping them reasonable. The second is having revenues to support what you're doing. Right now, in terms of our business model, Redwood Mednet is still expanding and still consuming capital. We're not fully sustainable based on services we sell. We still see targets, investment targets that will provide grant funding to help grow the solution. So our current model, growth model, we expect to be fully sustainable in 2012 after this growth spurt we're going to go through with the new ARA funds. The other side of it is that a lot of HIEs misunderstood how comprehensive the technology needed to be, spent too much on technology, and had no cash flow to support that technology. So it's really important to understand how to keep your costs down at the level of the actual change management that's going to happen in the local workflow. For the Regional Extension Center, we're a gold service partner. We don't install EHRs, but we enable health information exchange, and we're signed up as one of their service partners. In California, we don't call it the state designated entity, we call it the state governance entity, and I participate on their advisory panels, and I'm looking forward to helping move the process forward. I see three main challenges for Redwood Mednet, and none of them are technology. They're all policy or business model. The first one is that I alluded to it earlier. The organizations in our neighborhood are silos, and the silos are very competitive, and they see no reason to share data. I was on a panel with the chief technology officer of a local integrated delivery network, and he said flat out at the panel, well, we have full CPOE in our hospitals, we have an EMR in our clinics, we're essentially paperless, we see no reason for health information exchange. In another case, we've got a local IPA that basically declares themselves a health information exchange. The issue is that they see no business case for going outside of their competitive boundary. And so what I see in my neighborhood in Northern California is the rise of multiple silos that don't talk to each other. And the second part of this is, the second challenge here is that from the perspective of the small unaffiliated providers or the small hospitals that we work with, Any interface requirement is a barrier, and Redwood Mednet is designed to solve that barrier. So, you know, the first big challenge is silo enterprises that don't see a business reason to interoperate. The second issue is again a business model issue, and that is that even if we've got an integrated delivery network that wants to exchange data, but they haven't figured out the legal agreement that will enable them to. They're held back by the risk management side of their business. So, for example, I was fairly disappointed that the recent Nationwide Health Information Network trial implementations did not produce a live DIRSA that could be completely in production and released and ready for local communities to use. It's still hung up in this federal onboarding process, and that was, you know, the trial implementation finished almost 2 years ago, and now we've got tiger teams trying to make breakthroughs, but it's a barrier right now. And the third area is that health information exchange and electronic health records is actually not a software installation. It's not a technology problem. It's a change management issues for facilities that need to have optimal business processes. And I am constantly struggling with organizations that think that it's all about technology, when in fact it's not. It's about the users and their workflows and how they leverage the tools that electronic data provides them with. There's an adoption issue here, because in our neighborhood, all PHR, or consumer engagement activities, are tethered to an organization, and a patient-facing organization, and we're not a patient-facing organization. On the other hand, I can see us enabling patients to acquire data, and in fact it's explicitly written into our policy manual how to safeguard that. There's a technical problem between us and handing data to a patient, and that is that because we're essentially a business-to-business service between healthcare businesses, we don't have a way to authenticate an individual patient that they're not some bot that's trying to scam us for, you know, some privacy spill or identity theft. So there is a policy issue that has to be solved, so that we can be confident that we are in fact responding to a legitimate query and enabling some data to flow out. So when that's solved, that'll be a big watershed event. Until then, we're really working between the businesses that have the data, and it's most efficient for the patients to be tethered for now, but that hopefully will change.